All right, thanks for joining us for another episode of Ultrasound Cases. Again, we're going to stroll down memory lane, go through the emergency ultrasound scrapbook of great cases. So we'll see what we have in this edition. All right, it's closing time. So this is a patient, they had presented to the clinic with some dyspnea. It's getting close to 5 o'clock. We usually see an influx of patients in the ER about closing time for the clinic. And so they had ordered labs, they had ordered a CT chest, but they weren't going to wait around for the results. So they bring them in, hey, we're just going to park the patient in this bed. You don't have to do anything. Just let us know when you get the results and we'll let you know what to do. No problem, right?
Closing time.
Yeah. Very dangerous.
The lights on over every.
All right. So 68-year-old male, history of smoking, hypertension, had some sort of chest surgery last week. He's short of breath. He doesn't feel good.
Sounds bad.
Oh, don't be so negative. Come on, he presented to the clinic. How bad could it be?
It's either going to be a PE or tamponade.
Even before
See
we
this
progress,
coming.
I just got to point out the legal liability of just dumping them in your ER and telling you not to do anything. Just call me with the test results and I'll take care of it. I mean, you're responsible for
Oh,
this
this
guy.
is a small town.
you're-
We help each
you
other.
get together.
Of course, we're
Yeah.
going to evaluate him. But so
Did they specifically say don't look at his heart?
I said, don't worry, we're just going to park him here. I
Yep.
don't know if they had registered him, but I was working with a 30-year nurse, and I remember, so the guy's laying in the bed, and she looks over at him. She's like, you need to go evaluate him. I'm like, wow, how about you go do some vitals? So,
No.
90 systolic, a little bit tachycardic, setting 93% on room air, afebrile. Take a look at him, got a mid-sterniotomy incision, doesn't look infected. Don't hear a bunch of crackles or anything. Get a little bit of lower extremity edema. So not really exciting. So just kind of going through, went up, did essentially limited echo, standard subcostal view, right? So you're just going to be looking through your liver, coming through. So your RA, LA, RV, LV, right? No problem. You can get this in a few seconds. Then we moved on and did a few other views also. So just enhanced image of what normal looks like, because we've looked at a bunch of normals, and because we know what normal looks like, it's pretty easy to see abnormal, even if you're not sure exactly what's going on. So, right, normal subcostal, beautiful looking.
Mm-hmm.
No problem. Go over to the IVC. And here's what I got with this guy. So, the far field imaging is not the best, but I think what we could see there.
This problem is common after cardiac surgery.
So here. And there's the apical view. So big pericardial effusion. You got collapse of the right heart. And again, the nice thing is actually when they have something like this, it almost creates its own window. It's actually quite easy to see the heart
Absolutely.
from almost everywhere.
You don't find that the best way to diagnose this with CT?
Well,
Or cardiology.
eventually we would have got to the diagnosis, right? We were just waiting for the results of the CT.
Sure.
Yeah. The one benefit of CT in this is you can put the Hounsfield units on it and tell is that blood or it doesn't really matter. It needs to.
You
get
think you
drained.
got a non-bloody effusion 3 days after surgery?
Who knows?
No.
Probably not.
So
it doesn't really matter. You're
So
gonna drain it.
you got this image, and you know what's wrong, and you guys aren't familiar with this because you've not worked at a small hospital, but you have to get someone to take this patient. All right? So you call your neighborhood cardiologist at the next closest facility,
Sounds.
and he's like, sounds stable, vitals are okay, had surgery last week, why don't you admit him, and we'll see how it goes overnight.
See, I would put a pericardial drain in that because with his vitals and his symptoms, it's likely not to happen. It's likely not to happen in a timely manner. And I'm worried about, even if I send him to another hospital and he goes to a step-down unit and arrests in the middle of the night, then I feel like that's on me.
So
When
let
I
me
can
come
put
to
a
the same
I can put
conclusion.
a pigtail drain in
Yeah.
it easily and just then send him.
Let me go the same pathway and a just slightly different articulation of the rationale. Is that this thing is undergoing pressure volume curve phenomenon, and if he just gets a few more cc's in there, his pericardial pressure goes way high. His filling pressure drops off to 0. It's not a gradual process. It happens very suddenly with just a few cc's. So I agree with Rob. I would doing that before sending them.
And just so now, the
If a
back,
guy like this has if he has a cardiac arrest, you're not supposed to do CPR on him, right? You're supposed to cut his chest open and do internal massage.
We're prepared for
I
that.
think I'm up for preventing that instead of watching it happen.
so, but you just learned point of care ultrasound. Your infancy, you're like, this doesn't look good.
You look at a pericardial
you got,
centesis lecture,
but you
it's
feel,
easy to do.
so you feel like you got bad advice.
Yeah.
And you're like,
Yeah.
I don't think this is good. So you call another facility. And you explain the situation. And you actually call the facility where he had surgery. And he's like, fly him down. So he didn't get a pericardicentesis.
Yeah.
He got a pericardial window.
Sure.
But again, quick case, certainly just taking a few seconds to look at the heart, especially when you have that pericardial effusion,
I
creates
bet if
its
you
own
called
window.
that same guy and said, I put a drain in already, he'd be like, awesome, thank you.
Yeah.
He wouldn't have a problem with it.
But this was a while ago.
Yeah,
Just,
yeah.
But you could throw a spear at that thing and hit the right spot.
Oh.
You know that.
Well, and if you did the linear approach with the linear probe,
Yeah.
you know, it's not going to be hard to do.
This is before that was invented.
Yeah.
Okay. So
That was invented in Indonesia, by the way.
Yeah. In the 80s.
So just a simple, straightforward case, just taking a look at the heart in these people give you a lot of information.
Oh yeah.
And then knowing when you get bad advice. I think deep inside, when you see an image like that, and this was before texting and before, like, I think I would have had to send I would have had to probably done a thermal printout of this and then faxed it to him.
That was my next question. So cardiologist number 1 never saw images. He just
You could-
sounded stable.
This is before any of that.
Got it.
Landlines.
phones
Are you
were around.
familiar?
Yeah.
Rotary dial.
Phones were around.
So
Good.
but where you had to make your own decisions without telling anything. So again,
good.
another good case.
If you would like to easily and safely manage this life-threatening condition and you have 3 minutes, click here to learn the best approach for pericardiocentesis.